Okay, so it's 2:35. I will start. We have all the speakers in room. Welcome everyone. Thanks for joining today. It's real great. It's really great for us to have this place to discuss this topic. We started a neuromuscular clinic 3 years ago in here at the Heart Institute with Dr. Lamacie, and we were just about to do a journal club in EP, and we were discussing what are we doing with these patients. And heart failure was in the same page saying, what are we doing with these patients? So I said, why don't we start a new neuromuscular clinic? And this is how we started at the Heart Institute, and I can't imagine any other situation that we need to collaborate more with the different doctors or physicians following patients with neuromuscular disease as this. So it's great to have this opportunity to discuss this topic with you. So we will start presenting a few cases. It's the first cases will be presented by Nina Ghosh, who's Dr. Ghosh is co-leading the neuromuscular clinic or cardiac neuromuscular clinic with me at the Heart Institute. So Nina, whenever you are ready to start.
Perfect. Okay. Thank you so much. And I'm very happy to be here to hopefully advance the care of these patients and the science. Let me know if you can see my screen. Just going to share my screen. Can you guys see my screen?
Yeah, we can see it, but not in slideshow.
Oh, I'll put it in the slideshow mode. Perfect.
You might have to exit and then go back.
That's
the
perfect.
slideshow.
That's
there you
perfect.
go. It's
Does
fine.
that work?
Yeah,
okay.
perfect.
Perfect. Thank you so much. Hey, thanks very much. And these are my disclosures. I'll just give a quick overview of kind of the purpose of the talk. I'll start off with a few case examples that will lead to a review of the more common neuromuscular and diseases and their associated cardiac conditions. Common is an interesting word because these are all rare diseases, but collectively they encompass a lot of patients. And then I'll just quickly review the approach to diagnosing and monitoring these patients. And we have another speaker, Dr. Esteso, later on that will speak more to the treatment and approaches to caring for these patients as well. So I'll just start off with case AA. He was actually initially picked up by his family doctor in 2015 at the age of 20 and referred to neurology for a suspected myopathy. But retrospectively, there were signs that there were issues. He was toe walking and he didn't walk until he was the age of 3. But by the time he was diagnosed, it was 2015 where he got EMG studies. And then looking back at his family history, he had a maternal uncle with muscular dystrophy who required a wheelchair. So he was diagnosed with Becker's muscular dystrophy in 2016. At that time, the diagnosis of the Becker's muscular dystrophy, he fortunately underwent cardiac screening. I don't have an ECG from at the time of diagnosis because that was not available on our EMR, but a more recent one is an illustrative ECG of a muscular dystrophy, and Becker's muscular dystrophy can be quite variable, but often you can see evidence of hypertrophy, right ventricular hypertrophy, infarct patterns, repolarization abnormalities. You might see evidence of pre-excitation because of abnormal muscle bundles. So you can see here that he has a lateral infarct pattern. And if you correlate it with MRI, Dr. Lamacie will probably show us it might correspond to areas of scar. He ended up having an echo, and what you can see is that he had severely dilated LV and an EF of 30%. And that was at the time of diagnosis of his actual Becker's cardiomyopathy. He was seen by cardiology shortly thereafter. Unfortunately, he had comorbidities. He had an acute psychotic episode, and He was non-adherent to any of his cardiac medications. He didn't follow up with any of his cardiac appointments for 3 years. And finally, he presented to a peripheral hospital in essentially cardiogenic shock. And by that time, he had biventricular dysfunction, 2 large LV apical thrombi, and what was worsening his condition was that he was also diagnosed with acute segmental and subsegmental PE. Fortunately, he survived that hospitalization, and he was discharged on some goal-directed medical therapy, including ramipril, bisoprolol, spironolactone, and apixaban. Despite that treatment, his EF remained low, so he got a primary prophylactic ICD. Thereafter, he had his ICD interrogated. No real arrhythmias detected during his ICD insertion and thereafter. Unfortunately, he continued to have biventricular dysfunction, and his family had severe social and economic hardship that kind of prevented them from having coverage for optimal goal-directed medical therapy. Finally, we were able to switch him to Entresto from the ramipril. We added SGLT2 inhibitor, and I think Dr. Esteso may talk more about that treatment, spironolactone, a beta blocker, and we were limited at that point. So by the time he was optimized, unfortunately, he had ongoing severe biventricular dysfunction, but his TR had improved. Unfortunately, just a few months after I saw him, he called 911 because he was acutely short of breath. When the EMS arrived, he was quite hypoxic, and then suddenly he had a cardiac arrest. Unfortunately, there was no shockable rhythm during his cardiac arrest. He underwent over an hour of both CPR combined with ACLS, and there was no return of spontaneous circulation. There was consideration because of his history of PE for giving him thrombolytics, but because he was already quite oozy from all of his IV lines, that wasn't pursued, and he unfortunately passed away. So that's a sad case, but I thought I'd offset it with a not less sad case of a 62-year-old man. He was diagnosed at the age of 26 with Becker's as well. He actually didn't present until he was in his 20s, and his gait difficulties and other issues were addressed through rehab. Unfortunately, he presented for the first time in 2019. He had a syncopal episode, admitted to a community hospital, and essentially had cardiogenic shock and had an ejection fraction of 11%. He was transferred to the Heart Institute again for management of the shock, initially needing inotropes, but fortunately again discharged on some low-dose goal-directed medical therapy. Unfortunately, that admission set him back quite a bit from a mobility standpoint, and he lost an ability to walk and transfer. He continued to have low EF, and so he received a single lead ICD. Then he developed presyncope and was found to be in complete heart block, received CRT upgrade, and we were fortunately able to up titrate and put him on optimal goal-directed medical therapy. And actually, he's improved quite a bit from a functional standpoint. He's exercising within limits with a TheraBand. He currently uses a scooter and a wheelchair. He plays music. He plays the drums, piano, and guitar. And we've managed to get his ejection fraction from 11% to 30%. His RV is normal and his valves are normal. So he's still doing quite well, relatively speaking. So I wanted to show these two somewhat contrasting cases because they raise some important teaching points. One is that obviously cardiac complications can contribute significantly to both morbidity and mortality in neuromuscular disease. Muscular dystrophy in particular, the dominant cardiac problem is cardiomyopathy. And in adults, when we see adults, there may be significant LV dysfunction, especially at the diagnosis of their underlying muscular dystrophy in terms of Becker's. Usually Duchenne's, and we'll talk about that later, is diagnosed in childhood. And so their cardiac status can be monitored sooner than they develop LV dysfunction. But these patients are complicated. They're competing comorbidities, complex social situations, whereas some of our other adult patients, we kind of discharge them from our clinic if they don't show. These patients, you know, often we hear later on they didn't show up because of weather, not getting transportation issues, burnout, and then mental health issues, intellectual issue, disability can complicate their treatment. And if they have a cardiac complication, this can set them back in terms of their skeletal muscular issues. So early involvement of a cardiologist can mitigate both hospitalizations from cardiac causes and cardiac comorbidities, but also improve their overall quality of life. So I probably, for the sake of time, I won't spend too much time on the next few slides, but I just wanted to, for those who aren't familiar with neuromuscular diseases, review some of the more common ones. And a nice, if you don't have time, since we don't have time to go over everything, if you refer to this statement from 2017, it gives a nice overview of the neuromuscular diseases and their cardiac abnormalities. It's the 2017 AHA guidelines. So most of these are genetic disorders and usually mutations that affect single genes. And they affect skeletal muscles and can often affect cardiac muscle, depending on the genetic basis. They're variable in terms of inheritance, so that family history is quite important when you're seeing somebody with a cardiomyopathy. They can be X-linked, as are the muscular dystrophies, autosomal dominant or autosomal recessive. And this is just a very noisy schematic of the cardiac myocyte, but for some examples of where the genetic defects can result in the phenotype. So muscular dystrophies affect the dystrophin gene. In Duchenne's, it's a more severe phenotype because essentially they don't produce any of the dystrophy gene, or very little, whereas Becker's, usually they have a mutation that leads to a truncated protein. In Emery-Dreifuss muscular dystrophy, for instance, the Emerin protein is affected, and in lamin A, the AC nuclear lamins are affected, and syndromically they have they're manifest as limb-girdle muscular dystrophy. So there are two types of cardiac involvement, including cardiomyopathies and conduction system defects with arrhythmias. Coronary involvement is less common, but can be acquired later in life with certain conditions. BMD and DMD, Duchenne's and Becker's, are the most common types that affect the dystrophin gene, and they are X-linked because they the gene is found on the X chromosome. Duchenne is the most severe phenotype, and there's progression to loss of walking independently quite early on in life, and the cardiomyopathies can develop quite early, but most commonly in the second decade of life. Becker's sometimes present in adulthood, and they have a more mild and variable phenotype. And the most common cardiac involvement, although it can be variable in both of these conditions, is dilated cardiomyopathy. Cardiac disease is the primary cause of mortality in greater than 20% of Duchenne muscular dystrophy. And in Becker's, up to 70% develop symptomatic heart failure by the age of 40. I think I might skip over these slides just because we're running out of time, and you can read from the documents more details about these other conditions. And I just wanted to review what is important in general in the evaluation of these patients. What we can see, it's a multi-system disorder, so you need a collaborative approach. One downfall of our current approach to heart failure in general in these patients is that the scoring system for functional status in these patients can be falsely reassuring because their mobility is limited, and we can't apply the same NYHA status rules to these patients. So they can have marked LV systolic dysfunction, as we saw in our first two patients, without having any seeming symptoms. And some of these symptoms can be attributed to skeletal muscle weakness. So evaluation of and treatment of these patients before overt cardiac symptoms may afford patients the best opportunity for impacting their mortality. And so in terms of recommendations, all DMD and BMD patients should have an initial cardiac evaluation with ECG and imaging performed at the diagnosis of their disease. And for Duchenne muscular dystrophy, below the age of 10, the current recommendation is every 2 years. I don't know if that's what's done in practice, so we can ask the pediatricians. But beyond the age of 10 years, there should be an annual evaluation. And in asymptomatic patients with known LV dysfunction or any kind of arrhythmia, then they should be reevaluated at least annually, if not more. And if they're symptomatic, obviously, they should be reevaluated more frequently than annually, both clinically and with testing, depending on their clinical status. Female carriers of Duchenne and Becker's muscular dystrophy may not have any or very minimal skeletal muscle manifestations, but still have evidence of cardiac involvement. So starting to the second or third decade of life, these patients should be evaluated every 3 to 5 years with cardiac assessment, such as echocardiography and ECG. Mariana will talk about the role of advanced tissue imaging modalities, such as a cardiac MRI, and the role of ambulatory ECG monitoring in these patients will also be discussed. And if, as with other patients with LV dysfunction that persists, consideration may be given to ICD insertion. The problem with the 2017 guidelines and data in general is that pharmacological investigations of cardiac care may be more specific to DMD and BMD, and data regarding ARNIs and SGLT2 inhibitors that are high quality are still lacking. So we're using them empirically. And I'm just going to end there. And I don't know if we have enough time for questions. So maybe if you have any, you can put them in the chat. Can you still see me? And I'll stop sharing my screen.
Yeah, I think maybe we should move forward with the second case, so we have time for the other presentations. So Ghaith will, Dr. Almidani is going to present one of the cases that we're following in the neuromuscular clinic at the Heart Institute. Ghaith, whenever you're ready, thanks for joining us.
All right, thank you. Let me just share my screen here. Do you see my slideshow?
Perfectly, yes.
Yep.
Excellent. All right, good afternoon, everyone. Again, my name is Ghaith Almidani. I'm an electrophysiology fellow working with Dr. Klein. Today, I'm going to present a case again to add on to the first case that I presented with the excellent overview there from an electrophysiology perspective. I guess this is our 38 years old patient. In short, type 1 myotonic dystrophy, multiple paternal family members with type 1 MD as well. None of them are known to the patient, at least, to have any cardiac manifestation prior to the time of the assessment. He also has a frontal benign brain mass that's been stable for many years and been followed, calcified in the frontal lobe. The other aspect of his life, or the most kind of challenging, which we're going to talk about in a bit, is he's a firefighter. He also works in a farm, drives trucks, and uses heavy machinery on a regular basis. So this guy has very minimal symptoms, unlike the first cases we heard about. So he has very minimal musculoskeletal symptoms with, sorry, just occasional jaw stiffness, but otherwise asymptomatic from an MSK perspective. From cardiac standpoint, no symptoms whatsoever, no heart failure manifestation, no syncopes, palpitation, and no exertional symptoms. He was referred to the electrophysiology team, or he was been assessed by EP team primarily for risk assessment from an arrhythmia perspective. as these patients, as we heard earlier, not only develop systolic and systolic dysfunction and heart failure, but also are at increased risk of arrhythmia compared to the general population. The patient was seen in 2021, but in retrospect, this was his ECG even from 2018. So he does have normal rhythm, sinus, no higher grade conduction block. His QRS is wide with a QRS of 140 millisecond, borderline PR, still within the normal range, and some occasional PVCs superior directed there that we do see on the ECG. He had an MRI as of his regular surveillance back in 2018 as well that showed minimal changes, mild LV dilatation with borderline function, decreased left ventricular function, small area of mid-myocardial LGE in keeping with non-ischemic cardiomyopathy. And this, with his established diagnosis, is in keeping with the cardiac involvement of his myotonic dystrophy. Now, the patient was seen in 2021, and as you see here, the ECG really look not much different. So we know at least that between 2018 and 2021, his electrical profile remained stable. The PR remained similar to that within the normal range, and the QRS is exactly 140 as well, unchanged. He had another echocardiogram in 2021 at the time of his initial assessment. Similar finding compared to his previous ones from years before. Some thickening of the proximal septal portion of the left ventricle with no obstruction and no other valve disease. Ejection fraction remains in the low 50s, similar to what it was before. Now, with that, and we're gonna show the guidelines, people who have neuromuscular disease, when they have established or documented conduction disease, as presented in that ECG, the usual recommendation or guidelines that they are at increased risk compared to general population. And we usually in the electrophysiology do offer them devices, either ICD or pacemaker, depends on the situation and the discussion of the patient. Now, this patient was a firefighter. The patient used heavy machinery, and as you all know, having a device will have substantial implication on his lifestyle and what he does on a daily basis. And that's why we decided to go ahead and do an electrophysiology study, which is really an intracardiac electrophysiology assessment of the conduction profile in the heart to further risk analyze or risk assess the patient. Here you can see intracardiac catheters inside the heart, with this being at the Hess Purkinje at the Hess point. And what we're measuring here is really the HV intervals, we call it, or the Hess ventricular signal that talks to the ventricular ventricular involvement of the conduction disease. This remains to be outside of the normal range. 58 and 59 is outside of the norm. Usually it's below the 45, 40 millisecond. The guidelines calls it 70, which I'm gonna show the pictures of that as a cutoff for interventions or for higher risk compared to people with normal HV. But again, the 58 remains to be abnormal. And here what we did is incremental pacing from the atrial chamber in an attempt to find what's the Wenckebach, and the Wenckebach was around 157 beat per minute. So again, not a fully robust conduction system, but it was good up to that point. A Holter monitor was done around, so that was back in 2021. Discussion with the patient. Despite the recommendation, despite the risk and benefit, the decision was to continue to observe rather than give the patient any device, primarily with his lifestyle. And the patient was seen again in 2023, last year, with essentially not much of changes in his parameters. The Holter monitor showed sinus rhythm with some extra beats, but no sustained arrhythmias and no bradycardias. His ECG again in 2023 is fairly similar to the one from 2018 with no changes, suggestive potentially of stable electrical profile or conduction system. And the MRI, again, doesn't show much significant changes compared to the one from 2018, as you can see here, with similar borderline low function and the same pattern of LGE noted in the infralateral septal and the infraseptal portion. So again, from an arrhythmia perspective or electrophysiology, the questions usually we see these patients is for arrhythmia assessment, and what to do with the patient is the question that we have from an intervention standpoint. One would be observation, no device implantation, assuming that the risk of arrhythmia is low. Two is a pacemaker implantation if we think that the conduction or loss of conduction would be at higher risk. And then ICD implantation also comes to play. There is actually a fairly recent HRS Heart Rhythm Society expert consensus statement or a guideline in 2022 that talks predominantly at the arrhythmia risk assessment in patients with neuromuscular dystrophy and gives nice kind of algorithm for guidelines for different disease profile. So for patients with DM1 and DM2, as you see after the cardiac evaluation, if there is any conduction disease with a QRS being abnormal, prolonged PR, or obviously any high-grade AV block, these patients, as we mentioned earlier, by default go ahead to offering a device, which is an ICD, assuming the patient, assuming that's within the goals of care of the patients. And usually the EP study, what we did is reserved for patients who do not have any apparent conduction disease on the 12-lead ECG, but there is a symptoms that's undifferentiated and may be suspicious for an arrhythmia, either syncope or unexplained syncope, etc. And these patients usually end up by having an EP study or electrophysiology study, and based on that, obviously, if there is an inducible VT or a VF, then these patients get an ICD. But if not, the HV or the HV interval comes into play, with 70 being on the generous, higher border of abnormal. And if the HV was abnormal, again, the patient will go into getting a device. So that's the current recommendation, and that's a detailed document split it by different disease type and phenotype. That will be essentially it for the case.
Thank you very much, Ghaith. That's a good case. I will not go further in the discussion. I have two comments very quickly to do because we're running a little late. I think the case showed how patients can be affected by conduction disease even without any neuromuscular symptoms at all, and that's how it's important to follow them up. And another point that I see in this patient is how complex are this population, this type of patients. For example, discussing with this young folk with no symptoms and very stable disease, just to put an ICD, it's very challenging. In the other a part of the spectrum is the individuals with a very affected LV dysfunction that we are recommending ICDs or CRTs with people in patients in a wheelchair or very hard to assess heart function or clinical status. So I think we should move forward. Dr. Ghosh, if you want to present Dr. Esteso, and we move forward with the agenda.
Thanks very much. We have the honor to have Dr. Esteso, and if I'm pronouncing it wrong, please correct me. He is actually an instructor of pediatrics at Harvard Medical School, and his background is that he attended the University of Florida and Florida State University, where he obtained his undergraduate degree in chemical and biomedical engineering. Then he did an MD, PhD at Johns Hopkins University, and he worked in the lab of Dr. John Gerhardt, studying developmental biology, cardiac differentiation of embryonic stem cells, and cardiac reprogramming. Then he moved to the Boston area to pursue pediatric residency, pediatric cardiology fellowship, and then specialized training in heart failure and transplantation. So just for that, you deserve a Nobel Prize, all of that training. So he's remained at staff at Boston Children's Hospital, and he's with the Department of Advanced Cardiac Therapies. He's interested in complex heart failure, anticoagulation, VAD, and of course, neuromuscular cardiomyopathy. That's why we invited him to the talk. And he leads the care of these patients, the neuromuscular cardiomyopathy patients at Boston Children's Hospital. And he's an active member of the Action Muscular Dystrophy Committee, and hopefully he'll tell us a bit more about this if there's time, about what that involves. And his research interests include clinical trials of pediatric heart failure, dystrophinopathy, and anticoagulation, among other many things. So I will ask him to start his talk on cardiomyopathy in this patient population and where we go from here. Thank you very much.
Thank you, Dr. Ghosh, Dr. Klein. Can you hear me well?
Yes, did we pronounce your name correctly?
Perfectly.
Okay.
Can you see my screen?
Yes, we can.
Great. So thank you for the opportunity to talk to you guys a little bit about this topic that I feel pretty passionate about. And that is, how do we optimize heart failure care for our patients with neuromuscular diseases? I took a piece of your slide and included it in mine, so I hope you don't mind.
Oh, not
I unfortunately have no financially relevant disclosures to give you. But I do want to take a little bit of time to tell you about cardiomyopathy and neuromuscular disease, and Dr. Ghosh has done this already. I'll talk a little bit about heart failure management. We'll bring up the subject of penetrance. And as a pediatrician, I will use Duchenne's as a way to illustrate the prophylactic approach to cardiomyopathy management and neuromuscular disease, and to encourage you guys to think about when is the earliest sign of disease in cardiovascular disease in this patient, and what is our opportunity and perhaps even our responsibility to optimally care for our patients with that. I will add a word of caution, a little summary, and I'll ask for questions. You've seen this slide already, but essentially says that mutations for neuromuscular disease are all over, in, on, and around the cell, the cardiomyocyte. And as Dr. Ghosh mentioned, they're rare monogenic diseases which affect primarily striated muscle. But in these patients, there's potential for cardiac involvement, maybe cardiomyopathy, primarily dilated, but there's restrictive and arrhythmogenic cardiomyopathy in patients. And there's, as you notice in those well-presented cases, some concern for arrhythmia and conduction abnormalities as well. And so what does that mean for our patients? And this is now old data from the Pediatric Cardiomyopathy Registry. And these are three competing outcomes graphs that taken together represent three groups of patients who presented with dilated cardiomyopathy type phenotype. And so at time 0 on the x-axis, you'll see that everybody starts with their own heart alive. And as time goes across the y-axis, then some patients get transplants, some patients die. And across any one time point, the total sum of patients will be 100%. And if you take the first graph, you see 14 years of data, and you'll notice that for patients with idiopathic or familial dilated cardiomyopathy, and those graphs are essentially identical, the vast majority of the patients, about 50% of the patients or 60, are still alive with their own heart around 10 years, with about 30% of patients having undergone a transplant, and a little bit less than 20% having died. When you compare that immediately to the graph in the middle with patients with neuromuscular disease, you'll notice that those are very different. So at 10 years, about 30% of patients with neuromuscular disease, and this is 10 years just from the time of diagnosis, about 30% of those patients are still alive. More than 60% of those patients have died, and there's less than 10% of patients who have been transplanted. And just for comparison, I added myocarditis, and obviously the outcomes in those patients are much better. If you compare this specifically to patients with dystrophic cardiomyopathy, you'll see that, granted, with very small numbers, the patients with Duchenne's do very, very poorly in terms of survival since diagnosis, much worse compared to patients with other dilated cardiomyopathy, and patients with Becker's cardiomyopathy do better from the time of diagnosis. Though, as you demonstrated, that gets harder later on. And so, how do we think about our patients? And I'm sure you've seen these stages of heart failure. And so, for all of our patients with a known pathogenic mutation in the absence of symptoms, they're already in the stage B pre-heart failure stage. For those who have had or have heart failure, they're in stage C, and those with refractory heart failure are in stage D. And so what we do in terms of thinking about their heart failure management is that for patients in stage B, it is reasonable when you start seeing abnormalities, and the question there is how hard are you looking, to think about initiating some reverse remodeling therapy with ACEs or ARBs and potentially think about beta blockers. For patients with stage C heart failure, we think about goal-directed medical therapy. And for patients with advanced heart failure, we think about advanced heart failure therapies. And the way I like to think about the benefits of guideline-directed medical therapy is this graph that's a little bit adapted from a review or a meta-analysis, rather, published a little bit over a year ago, that looks at the hazard ratio for mortality for some of our common drugs. And so placebo is the second line from the bottom, digoxin is at the bottom, and you see no cardiovascular mortality benefit for those medicines. But as you go up in potency and start adding medicines to one another, you see that the hazard ratio for cardiovascular mortality decreases progressively. And right now, in this study, the best combination, all other things being equal, would be using an ARNI, beta blocker, MRA, and SGLT2 inhibitor. So what about our patients? So the issue of penetrance is something that is front to mind to me as I see families and patients with the concern for neuromuscular cardiomyopathy. And so penetrance is the extent to which a gene is expressed phenotypically. And it is very variable in genetic cardiomyopathy. And it can be the same for neuromuscular cardiomyopathy. You can have a patient with myosin heavy chain who has a very strong neuromuscular phenotype, has no neuromuscular phenotype, and who has a very strong cardiac phenotype or no neuromuscular phenotype, and it can be all over the place. And there can be some difference in a generation with the same, across generations with the same mutation. But one thing we know for sure is that patients with dystrophinopathy, that is, boys with dystrophinopathy, particularly with Duchenne's, have 100% penetrance. And there's that question of how hard are you looking? There are many boys with Duchenne's in whose echo looks good at 20 years of age. And what I end up telling them is, your heart's not normal. And there are other ways to demonstrate that, but it is important to keep that in mind. As respiratory care improves, cardiac dysfunction has become the leading cause of death for patients with Duchenne muscular dystrophy. And it is, in my opinion, for all these young people with neuromuscular disease, an opportunity for us as cardiologists to think very hard about when to treat patients, and certainly a cause for optimism. So what about Duchenne's as this example of prophylactic care? So you guys know Duchenne's, to me, is a chronic progressive illness with multi-system muscular failure, and that includes skeletal, respiratory, and cardiac muscular failure. And there are many important things, but these boys, as Dr. Ghosh mentioned already, go on to have motor difficulties, loss of ambulation, respiratory compromise, and they die early. So some data suggests, and I certainly have patients older than this, the most recent data suggests that patients born after 1970 have a mean survival of 29 years of age, which is just not long enough. How do you diagnose these patients? You've gone through this, but high index of suspicion, some lab testing, and then genetic testing for confirmation. in Duchenne's and in Becker's, and in women with dystrophinopathy, it's dystrophin that's the problem, which is stabilizing the membrane, the sarcolemma, to the contractile proteins, and it leads to inflammation, cell death, and fibrofatty replacement of the myocardium. And all these non-cardiac management strategies are actually really important. So if you look at steroids, those boys walk longer, they have less respiratory compromise and restrictive respiratory physiology with avoidance of scoliosis, and their cardiac function does better. Even those patients who get steroids and have optimal care end up needing non-invasive respiratory support, which is certainly a way of treating the heart. And there are other novel therapies coming along, but mostly for neuromuscular support rather than cardiac support. So what happens when it comes to the heart? So for Duchenne's, which is our worst case scenario in terms of neuromuscular disease presentation, you have a mean age of dysfunction of 15, but I have 9-year-old boys with severe dysfunction with diffuse LGE who are on multi-drug therapy, and in whom, because they're so early, you might think about proceeding with transplant. It is important to know that dysfunction, certainly dysfunction appreciated by echo, is preceded by fibrosis and by normal diastolic function. It is slowly progressive, and we think we can stabilize it on medications. And this group here, who's in their 20s with apparently normal function by echo, are the boys that I mentioned earlier, that if you do an MRI, you see lots of fibrosis. Almost no one with Duchenne's has no fibrosis when they're in their 20s, and who has that presentation that they have a respiratory complication and suddenly their echo looks horrible in the ICU and they're asking you what's going on. What about fibrosis? It sounds like there's going to be more talk about this, but cardiac MRI is really important in the management of many of these patients with neuromuscular disease. I think it's hard to say that it's standard of care for everybody because not every center has it, but I do think it's really important. And there are centers who do it yearly. We do it every couple of years, but I do think it's helpful. And this is a paper from a while ago, retrospective review of patients in Cincinnati who've done a lot of MRI. And when you look at patients with and without LGE, those with LGE are older and have more dysfunction. And this is obviously an example of dysfunction that's characteristic in Duchenne. So we have limited data and there's a lot of practice variability, but I do think there's an opportunity for us to get together and think about how to treat these patients the same way. And this is just an illustration of how we all do things differently. This was questions asked from Action and Chet Villa that led this effort of providers of neuromuscular cardiology, asking when do you start ACE inhibitors, when do you start beta blockers, and the message is that we're kind of all over the place. And often we do it too late. You do the 2017 AHA guidelines and the 2018 care consideration working group recommendations, but we in Action, and Action is a quality improvement care collaborative that started around the care of patients with VAD, knowing that each of our centers had few of these patients, but together we could leverage our common knowledge. And it's gone on to do a lot of heart failure, a lot for pediatric heart failure. And there's, as you heard, a working group that's particularly dedicated to the care of neuromuscular disease patients. And what we've gone on to do, and this is a paper that's hopefully going to be published very soon, is come up with some recommendations that recognize that about half the patients, at least in the United States, are receiving even cardiac medications from non-cardiologists, sometimes from neuromuscular specialists, whether neurologists or otherwise, and giving specific guidance in terms of doses and timing for medications. And the data, all the adult data, the neuromuscular data in Duchenne's in children is interesting in that there's all these small randomized clinical trials. So this was one sub-study in Brazil, which looked at 76 patients and randomized 42 patients who did not have dysfunction. So these are the not dysfunction patients here. and they gave treatment or didn't give treatment, and then compare those patients by MRI at time 1 and then 2 years later. And they also had a group of patients who had dysfunction, and they had a group of patients who had no dysfunction but had no fibrosis. And so the study group was really these two lines: the patients with no dysfunction and treatment, and the patients with no dysfunction and no treatment. And what you notice over the 2-year span is that everybody's degree of fibrosis increased. Those that did not have therapy had a significant increase in the degree of fibrosis compared to these patients who had no dysfunction, started with fibrosis and got treatment, and their increase in the degree of fibrosis over time was not significant. A little bit convoluted. They also were able to demonstrate, and this is sort of well known, that the more fibrosis you have, the more likely you are to have dysfunction. And more importantly, all the adverse outcomes they saw in this small trial were associated with patients who had fibrosis. And they have 4 deaths, and those patients who died had higher percent of left ventricular mass that was fibrosed and lower ejection fraction. And there was more arrhythmias. There was arrhythmias only in the patients with fibrosis. This other study is a recent and very interesting study from France, in which they looked at centers that did Duchenne, specialized Duchenne care across the nation. And they compared children 8 to 13 years of age at the time of initiation of ACE inhibitors to those that did not. And they did this propensity score matching analysis over time. And in this retrospective large study, they were able to demonstrate that the initiation of ACE inhibitors in patients with Duchenne led to decreased mortality as well as hospitalization for heart. So based on all those guidelines, we actually think that you should actually start ACE inhibitors by age 10. I try to start all my patients by age 9, and I think that there's going to be a time when we start much, much earlier. We think it's reasonable to start prior to 10 years of age if you see ventricular dilation, and certainly any time that you see systolic dysfunction or fibrosis. But the question often is, when are you starting to look for fibrosis? The average age of fibrosis is about 12 years of age, but you can certainly find it earlier in a lot of patients. This is data from adults in the original Entresto trial. The trial for Entresto in children was equivocal, but we think particularly for older patients and those patients with dysfunction, it's reasonable to transition an ACE inhibitor to Entresto. What about MRAs? So this is a randomized clinical trial that looked at about 40 patients with Duchenne's and randomized them to eplerenone versus placebo and looked at their function and strain at time 1 and then a year later. And what you see is that there's a reduction in strain and improvement in systolic function for those patients on the eplerenone group. And this data has been the same, whether it's eplerenone or spironolactone, and it's a class effect. And so we think it's reasonable to consider initiation of an MRA in the setting of fibrosis, but you have to be looking for it. I think it's reasonable to initiate by age 12 if you're not doing MRIs. And certainly, I think should be initiated with any systolic dysfunction in a patient with neuromuscular cardiomyopathy, independent of whether it's Duchenne's or not. And it should be initiated with systolic dysfunction and elevated natriuretic peptide. What about beta blockers? This trial was not significant, but it randomized patients who were receiving ACE inhibitors to beta blockers and not beta blockers, about 40 patients. And what they demonstrated is that over time, patients who had beta blocker in addition to the ACE inhibitor, they had a slower progression in the degree of change in EF compared to the patients only in ACE inhibitor. Like I said, it was a small trial that was not significant. And based on that, we think that you should recommend beta blocker in the presence of systolic dysfunction. For some patients, it can be considered in the setting of sinus tachycardia, and it's certainly reasonable to initiate for arrhythmia. And when it comes to using beta blockers for heart failure in neuromuscular patients, my personal gestalt or practice is to start with metoprolol. And the reason for that is that many of these patients already have, as the case that was presented earlier, some difficulties maintaining their systolic blood pressures in a reasonable range. It may be that their cardiac output is sufficient, particularly as their neuromuscular function decreases, but I think using a selective beta blocker with no alpha effect gives you a little bit better opportunity to uptitrate your medications.
We don't have metoprolol succinate in Canada, by the way. We just have
Oh,
yeah, we suck.
do you have tartrate?
Yeah.
Yeah, there are lots of limitations with medications across borders for sure. But that's been my go-to. SGLT2 inhibitors are such interesting drugs, and they work through such varied and honestly hand-wavy mechanisms, whether it is through oxygen-free radicals, which certainly would be important in neuromuscular disease and Duchenne muscular dystrophy, or cellular energetics, or one of the other many proposed mechanisms. They work to improve both systolic mortality in both systolic and diastolic heart failure, and that's the improving mortality in heart failure with preserved ejection fraction is really unique to these medications. They are well tolerated. They have no hemodynamic effects. They're not effects on your blood pressure. They do make you pee a little bit more, so it's a consideration for patients with neuromuscular disease and management of diuretics in patients who are on all drugs. But I think they're rapidly becoming, in practice, one of our important tools in the armamentarium. And we're hoping and working to launch a trial in patients with dystrophinopathy for the use of SGLT2 inhibitors. But right now, we're really limited to case reports. In pediatrics, there's no data for heart failure, but there's data for diabetes. And I'll tell you from our experience in the heart failure world, that we're using this in younger and younger children pretty broadly and have not seen any significant complications other than bacterial urinary tract infections, which are well tolerated most of the time. The recommendation from our group in action is that they should be strongly considered in patients with an EF less than 40%. But in practice, I think as I see progression of this function, particularly in patients with dystrophinopathy, I'm reaching for an SGLT2 inhibitor to be added to our cocktail. And we have to recognize that many of these patients have evidence of diastolic dysfunction before the evidence of systolic dysfunction appears, and that fibrosis is part of their paradigm. What about additional heart failure promising therapies? I think we're going to have to see, but there's certainly data in adults for vericiguat in reduction of hospitalization for heart failure and mortality for any cause. And there's actually a pediatric trial in the early phases underway, so we're really eagerly awaiting results. There's data certainly for hypertrophic cardiomyopathy using mavacamten or the novel myosin ATPase inhibitors, particularly in the setting of LV outflow tract obstruction and reducing the need for septal reduction therapy, whether that is with alcohol or surgery, and reducing left ventricular outflow tract obstruction. And in this table, you see a crossover design in which the patients who started on mavacamten had a reduction on the LV outflow tract gradient, and then those patients who crossed over then had the reduction later. What about biomarkers? This is a study from UT Southwestern, if I'm not mistaken, looking at adult patients with neuromuscular disease, including patients with Duchenne's, and looking at what biomarkers would be predictive of mortality. And you have body mass index, maximal inspiratory pressure, and NT-proBNP on the tables. And you see significant differences in the survivors and non-survivors. And what I would say, particularly for pediatrics and Duchenne, so this does not apply broadly, is that there's this interesting entity called dystrophinitis, in which patients present with incompletely understood but myocarditis-like episode with regional dysfunction, ST segment changes, and troponin leak that has never been associated with a documented abnormality in the coronaries, though it certainly looks like an acute MI, and many patients have gone to the cath lab for it. It seems inflammatory in nature. They develop acute dysfunction and LGE in the areas that are characteristic for this disease. And it is incompletely understood. On the recent couple of patients that I've had that on, I think it's important to have baseline troponins to understand trajectory, but also the institution of four-drug guideline-directed medical therapy in those patients has, at least temporarily, led to a significant improvement in their acute systolic dysfunction, which is in contrast to historical data, but we'll see. A word of caution, gene therapy has arrived for neuromuscular disease. I think that's amazing. With my background in basic science, I can tell you that cardiac transduction is incredibly difficult, and that we have to temper the great promise and enthusiasm for our patients while certainly encouraging the field to continue to move along. And there is a real risk of cardiomyopathy. We've had a couple of patients with neuromuscular disease die with cardiomyopathy after gene therapy trials. And I worry that as we treat particularly children with Duchenne for neuromuscular indications with gene therapy, particularly virally transduced gene therapy, that we may see either silent cardiac changes that are going to lead to earlier cardiac dysfunction. And I'm just, on a personal note, very concerned about how we're going to make sure that that doesn't happen. And there doesn't seem to be enough oversight at this time, even though we're all at our own institutions trying to encourage pretty close monitoring. So in summary, management of neuromuscular cardiomyopathy is very much disease specific, and I took the opportunity to leverage Duchenne's to talk about how guidelines for heart failure management apply. I think that predicting penetrance and severity is really important and may aid in management of cardiomyopathy. And there is an opportunity, particularly for high penetrance, high severity conditions, for us to be aggressive and even consider prophylaxis, especially in Duchenne, which is 100% penetrant and morbid. I think earlier treatment provides a modification for disease, an opportunity for disease modification, but you have to have a high index of suspicion, and this is particularly important with gene therapy. We need more studies. So thank you very much. Happy to, I don't know if there's any time, but I'm happy to take any questions.
Thank you very much, Dr. Esteso. That was great. You went through every possible therapy that we can use in this population. I think we will let the questions for after the Dr. Lamacie's presentation, if you are okay with that. Someone have a question now? So if someone have a question, just raise your hand or just use the chat in the system. So I will present Dr. Lamacie. Dr. Lamacie is a good friend of mine and colleague, and she finished her training in Toronto in 2018. Then she joined the Heart Institute that year to work with the heart failure team. Also, she was training in cardiac MRI, and she helped develop in the cardiac neuromuscular clinic at the Heart Institute in 2020, and I think it was in 2022 that she left to a better weather. So she's now joining us from Auckland, New Zealand. So Mariana, thanks for joining us today.
Thanks, Andres. Although I don't really miss the weather in Canada, I do miss you guys. So thanks for having me here again this year. And let me just share my screen if I can here. Can you see my screen?
Yeah, perfect.
Okay. So I'll talk Okay, so I'll talk about the role of imaging and biomarkers in the assessment and management of the neuromuscular cardiac conditions. And I have no disclosures. So as it has been said before, the neuromuscular diseases is a heterogeneous group of rare genetic diseases that often lead to significant weakness due to the progressive muscular degeneration. These patients can have various cardiac manifestations, including heart failure, arrhythmias, and conduction abnormalities, and this can occur as a predominant feature of the disease. So imaging assessment, especially with echocardiogram and MRI, can assess the anatomy, global and regional function, as well as tissue characterization with inflammation, infiltration, and fibrosis. And there is a big potential to identify early disease and improve prediction of long-term outcomes on these patients. So as you all know, echo is widely available and easier to tolerate. However, this population can have suboptimal image quality due to chest abnormalities and so on. And LV function, as has been said before as well, LVEF reduction may occur late in the disease process. Although you can assess strain with echo, you'll also face issues with image quality as well. So MRI has no issues with acoustic window. This is the gold standard currently for functional and volumes. And it can provide not only strain assessment in addition to the function, but also tissue characterization and look for fibrosis, inflammation, and so on. It is though less available, and it does has prolonged scan times, which can be difficult and challenging for this population, especially due to scoliosis, respiratory weakness, some patients being on ventilators. And also, if they have frequent arrhythmias, this can affect image quality as well. This is a review paper we published in 2019 when we're just starting this work together with the neuromuscular neurology division in the Ottawa General Hospital. And you can see here that as Dr. Ghosh also mentioned before, different genes that can lead to different phenotypes, and they can be correlated to some more permanent arrhythmias or ECG changes depending on the phenotype, as well as different fibrosis pattern seen on the MRI. So, for example, the DMD gene mutations can lead to Duchenne, Becker's, and even the carriers having isolated cardiomyopathy. It's often described as subepicardial to mid-myocardial, and oftentimes transmural fibrosis, mainly seen in the infralateral wall, although you can also see in other parts, including the septum. These patients can have sinus arrhythmias and atrioventricular arrhythmias. However, the most prominent cardiac manifestation is heart failure. As compared to, for example, the patients with LMNA gene mutation that can have different phenotypes as well, such as amyloidosis, limb-girdle muscular dystrophy, dilated cardiomyopathy. They have more pronounced mid-myocardial, usually in the basal to mid-septal wall, and they have also poor prognosis with a significant ventricular or malignant arrhythmias and sudden death as well. This is a recent work published by the Alberta group, Dr. Gavin Alded, that showed the prognostic utility of MRI-based phenotyping in patients with muscular dystrophy. And you can see here that, sorry, are you guys seeing this at the top? I might be able to. so you can see that the different subtypes of muscular disease have different outcomes. So, for example, the patients with dystrophinopathies, they can have more heart failure incidents and hospitalizations, as opposed to the patients with myotonic dystrophies, as mentioned before as well. They have more atrial arrhythmias or conduction disease that leads to device implantation and less heart failure. And the patients with limb girdle can have also increased mortality. So they looked for different cardiac MRI markers related to event rate. And they saw that the patients that had reduced ejection fraction, but also had reduced strain parameters, and they measured different strain parameters like the longitudinal circumferential, but they also assessed the 3D principal strain, and they saw that all these patients had higher event rate compared to the patients that did not have those abnormalities. So they showed that clinically relevant phenotypic differences between the subtypes of muscular dystrophy patients. There was more prominent replacement fibrosis and LV dysfunction in the patients with dystrophinopathy. The patients with limb girdle had similar phenotype, but milder compared to the patients with dystrophinopathies. Patients with myotonic dystrophy, though, they didn't have much fibrosis, but they have reduced cardiac mass compared to the other patients. And they saw that the 3D strain offered strongest capacity to predict cardiovascular outcomes, especially the 3D minimal principal strain amplitude was able to identify patients at a 5.5-fold increased risk of MACE, superior over to just assessing ejection fraction. And the composite value of this assessment with EF was superior over EF alone for risk stratification. And this is just an example of how they assessed the strain amplitude in health controls, and this would be the value that they found in average for those patients, and they were significantly reduced in patients with dystrophinopathies compared to the other types of muscular dystrophy. So I won't go too much into that. It has been said before, but the dystrophinopathies are related to DMDG mutation, which is the largest in the human genome. It's an X-linked disorder, primarily affecting males, and the phenotype, as mentioned, Duchenne and Becker. Duchenne is the most common dystrophy in childhood, and the female carriers can have isolated cardiomyopathy. So I won't go much into detail as well, but just the gene mutation will lead to the abnormal dystrophin protein with dysfunction of the sarcolemma that will lead to ultimately to cardiomyocyte death and apoptosis. And this will lead to an inflammatory response with fibrosis formation, thinning of the fibrotic region that I will show in the MRI, and ultimately to dysfunction of like increasing ventricular volumes, decreasing diastolic and systolic dysfunction, and leading to heart failure. So the advanced cardiomyopathy, as also said, is the main cause of morbidity and mortality in the majority of the patients with Duchenne, given the now with the more advanced non-invasive ventilators, the respiratory is no longer the main cause of death in these patients. And as also said before by Dr. Esteso, there is a window of opportunity for institution of treatment. And we should look for that in the age of course, this lies more in the pediatricians, but in the preclinical or subclinical stage of the disease, when we can not really find any cardiac abnormalities, or to the stage that we can see already some fibrosis. If we look for that, then you can institute early treatment to avoid or to slow down the progression to a more end stage. In the Duchenne population, a randomized clinical trial by the DuPont group showed benefit of early initiation of ACE inhibitors, as has been shown before as well. And the MRI that was done on those patients had showed the presence of LGE, even patients with normal function. And also important to notice that the steroid use in this population also slows down not only the progression of the muscular symptoms, but also the cardiac involvement. The MRI can detect fibrosis before changes in EF, and the abnormal strain can even precede the fibrosis presence. So this is just an example of subepicardial enhancement in the lateral wall. And this is where it's mostly described in the basal inferior and infralateral wall in this population. And as has been, this is a large single retrospective study, but also as mentioned by Dr. Esteso with the Brazilian group, actually from Carlos, who was my mentor in MRI training there, the LGE does increase with age and decrease with decreasing LV function. And now we have more other tools with MRI to assess early diffuse interstitial fibrosis, such as T1 mapping and ACV. So this is just another example of a patient with Duchenne, and you can see with the MRI, you can assess dilatation of the chambers, subepicardial fibrosis, again here seen in the lateral wall and associated with thinning of the myocardium in that area. Here in this example, you can also see some mid-myocardial in the septum. You can assess longitudinal strain with reduced strain in that area of the fibrosis and increased ECV. So there is also recent data coming about regional 4D strain to predict cardiomyopathy progression in Duchenne population. And this is a study that is still a preprint, but I thought it was just interesting to bring the data of things that are coming out. And they studied 40 pediatric Duchenne patients, and they imaged them yearly for 3 consecutive visits. And they could, with using this strain assessment, they could differentiate patients with slow and fast cardiomyopathy progression. Slow meaning between first and third visit, less than 5% of difference in LV ejection fraction, and the fast more than 5%. I won't much go into detail, but just to point out again that the percentage of LGE, percent of patients with LGE, but also the increase of LGE, and you can see here again, mainly in the inferior and lateral walls, do increase with when time goes by. And that also between the first visit and the third visit, ejection fraction has decreased and LG has appeared or increased. As well, all the strain analysis assessment have shown reduced strain throughout the time. They also correlate the strain with the stages of heart failure. And they just give also, again, the reduced and progression of reduced strain associated with heart failure stages and function and presence of LG. In terms of the female carriers, as mentioned, about 50% of them will have at least one positive finding on MRI. They are at risk for cardiomyopathy alone. And it's now recommended that in early adulthood, they should be screened with ECG and imaging, preferably MRI. And if they don't have any positive findings, surveillance should be done between 3 to 5 years. But more frequent if there are symptoms or any positive imaging finding. And you should consider starting ACE inhibitors or MRAs if there is LV dysfunction or early fibrosis. And the pattern of fibrosis seen on these patients are very similar to the patients with Duchenne and Becker's, like the same subepicardial enhancement in the lateral inferior wall. The myotonic dystrophies are the most common dystrophy in adulthood. The type 1, it's a manifestation of the mutation from the DMPK gene, and the number of CTG repeats are associated with clinical manifestation, meaning that the higher the number of repeats, the worse the clinical manifestation. It's a multisystemic disease and can involve many different organs. The type 2 is a more subtle, it's a different gene and a more subtle muscular and cardiac manifestations. In this population, the cardiac involvement is mainly arrhythmias and conduction issues more than cardiomyopathy. However, you can see LV dysfunction and heart failure in this population as well. And current guidelines, as previously shown, as well, showing that there is indication for early pacemaker implantation on this population. So this is an example from one of our patients, is scanned at the Heart Institute in Ottawa. And although, as I mentioned, it's not most common to have fibrosis in the MRI, this is an example where you can see some fibrosis in the lateral wall, as well as increased ECV and reduced strain. LMNA-associated cardiomyopathy can be variable phenotypes, including limb girdle muscular dystrophy, amyloidosis, congenital LMNA, and they are associated with dilated cardiomyopathy and heart failure, but they are highly associated with malignant ventricular arrhythmias and sudden death. And MRI can identify LGE earlier in the disease, and also some data showing that carriers can have increased ECV even without LGE. So more and more data coming about genetic cardiomyopathies and associated with arrhythmogenic cardiomyopathies and different patterns of LGE seen on MRIs. And this is just to show that the LMNA gene, as well as TTN, are some of these genes that can be associated with or more arrhythmogenic type of phenotype. These patients can have what we call ring-like LGE type, and they are the higher increased risk for arrhythmias. And there would be 3 or more consecutive segments of enhancement in the MRI, usually affecting mainly the lateral and inferior wall, but can also affect the septum, and mostly basal to mid segments, and more in usually more in a subepicardial way, but can also be in the mid myocardial mid wall. The TTN cardiomyopathies can also have various phenotypes. The patients can have core myopathy associated with primary cardiomyopathy, and the truncating titin variants are most prevalent genetic cause of dilated cardiomyopathy. Biventricular dilatation and dysfunction are seen, and also diffuse fibrosis. Mainly, most of these patients will have a mid-wall fibrosis, and they're also more susceptible to have ventricular arrhythmias. As also mentioned before about myocarditis or genetic myocarditis, or maybe being like hot phases of these genetic diseases, it's important to keep in mind. This is a general cohort of in London, the patients that were admitted with acute myocarditis, more than 300 patients. They had MRI for ventricular assessment, and they had genetic testing done. And what they showed is that about 8 to 10% of those patients had some gene identified that were associated with either dilated cardiomyopathy or arrhythmogenic cardiomyopathy. So these patients can have periods of myocardial inflammation, and they can present, as Dr. Esteso mentioned, with chest pain, ECG abnormalities, including ST elevation and troponin elevation. This is just in the MRI how you would see the presence of fibrosis enhancement associated, correlated with edema or acute inflammation in that area. And it is described that myocarditis, especially in the Duchenne population, can be identified somewhat in some phase of the disease. It can be associated with changing of steroids, either changing the medication or decreasing the dose of steroids. And patients can present with myocarditis, as mentioned, with chest pain and all those things. And they might have coronary assessment, which would be normal. This myocardial inflammation has also been described as being a precipitating factor for heart failure, and also to be like a marker of disease progression. Important to keep in mind also that the ideal way to assess these patients in terms of biomarkers is with the troponin I, which is cardiac specific, as these patients can have chronic elevated troponin T that might be associated with the underlying condition. And this is another paper from the Alberta group again, evaluating the diagnostic and prognostic value of biomarker in heart disease and cardiac events in patients with muscular dystrophy. And they showed that the baseline BNP as well as the high sensitive troponin I were correlated or were able to differentiate between the patients with muscular dystrophy that did have or did not have cardiomyopathy. So important to note that the CK and the troponin T can differentiate patients from like health controls from patients with muscular disease. And for example, it can be useful in carriers. However, they did not differentiate between those patients that did or did not have cardiomyopathy or cardiac involvement. And other inflammatory biomarkers that they also checked on this work also did not differentiate between those with or without cardiomyopathy. And I think also important to note that they show here that the BNP, although elevated in this population, the cutoff is usually lower compared to other heart failure populations. And
yeah, sorry to interrupt. We have 2 more minutes for the end of the workshop.
Sure, this is my last slide. And then the troponin, also work showing that the troponin I levels can also correlate with LG seen on MRI, as well as with native T1 values in patients with Duchenne. So another important marker of or a way to early identify early disease or disease progression in this population. So with that, I conclude, and thank you very much, and happy to take any questions.
Thanks, Mariana. That was an excellent review. Thanks for joining us today. I have a question myself, and I think there is something in the chat. So about my biomarkers, what do you think in order to this a few slides that you showed at the end? What do you think we should do for in general, like in this population as like as a follow-up? Like should we do troponin BNP for every patient, even those without heart failure?
Yeah, I think that's a good question. And I think as also mentioned by Dr. Esteso, I think it's important to get at least a baseline on these patients. And so you can compare, like, at least when they have any presentation symptoms that you can compare with their baseline. I think we were normally doing, once they come for their annual visit, we were getting BNP and troponins as a routine follow-up assessment. But I think it's important that you have at least one baseline to compare.
That's awesome. Thanks.
I would agree with that. And I guess I would just add that there's a leak, if you will, in terms of signal from troponin T compared to troponin I. So even in patients with spinal muscular atrophy, you will often find low-level troponin T positivity, but would not find a troponin I positivity, which has been relevant in terms of their gene therapy monitoring.
I had a couple of.
I think that
Yeah, go ahead.
that work. Sorry,
No worries.
the work that I also showed from the Alberta group, they comment that the high sensitive troponin was more appropriate and specific compared to the non-high sensitive ones as well. I don't know what was your experience with that, Paul.
Yeah, I think in practice, at least in our institution, with whatever high sensitivity troponin T we're using, it hasn't been as good. I still think high sensitivity troponin I is probably the most specific.
I think this will be closing in a few seconds, so I don't want to not saying thank you for Dr. Esteso, thank you Mariana to connect, and thanks for all that organized. I think that we have further discussion to make, and it's good to connect with you all.
Hopefully we can stay in touch.
Yeah, we can stay in touch. I don't know if this is going.
Great. Looks like everyone's rejoining us. Well, that brings to